Hello. My name is Dr. François Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SEFO. In this conference we will talk about the segmentary passive mobility tests for cervical spine, used in osteopathy, also called mobility tests, or dynamic palpation. According to Seffinger et al. 2004, the studies on the segmental movement of the cervical spine have a kappa of 58%. According to Fernández de las Peñas et al. 2005, the lateral sliding test for the cervical spine, known as the Mitchell cervical test, is as good as a radiological evaluation for the diagnosis of intervertebral dysfunctions in the lower cervical spine. In the study by Piva et al. 2006, the measurements of passive intervertebral movements had a substantial to moderate reliability in the evaluation of C0-C1 mobility. Fair kappa values were observed for C2, and none to mild for other levels. Lakhani et al. 2009 studied the end-feel sensation of post-manipulative passive amplitude. The sensitivity was 93%, and the specificity was 67%, in healthy patients. In symptomatic patients the sensitivity was 90%, and the specificity 80%. The findings demonstrated that palpation of the end feel of amplitude appears to be a sensitive evaluation tool in the cervical spine. According to Rey-Eiriz et al. 2010, the postero-anterior sliding test, known as Gillet's quick scanning test, for the cervical spine, is just as good as a radiological evaluation for the diagnosis of intervertebral dysfunction in the lower cervical spine. C3, C4, C5 had high sensitivity, greater than 80%, and high specificity, greater than 70%. C5, C6 showed high sensitivity, 100%, but low specificity, 41%. In the study by Manning et al. 2012, on segmental mobility tests they showed agreements for the detection of hypomobility between 62 and 84%, and for the sensation of end of amplitude ranged between 68 and 87%. Kappa values on the more painful side were reasonable to moderate for the detection of hypomobility, 0.29 to 0.53, and for the sensation of end of amplitude, 0.25 to 0.50. Kappa values on the less painful side ranged from fair to substantial for the detection of hypomobility, 0.43 to 0.65, and for the sensation of end feel, 0.28 to 0.60. The 3D passive intervertebral motion test, in the sitting position, has sufficient clinical reliability for use in patients with neck pain. According to Ogince et al. 2007, the flexion-rotation test for C1-C2 has a sensitivity of 91%, and specificity of 90%. The general diagnostic precision is 91%. Burns et al. 2016 indicated that tests for shoulder and cervicothoracic mobility vary widely. Kappa between -0.24 and 0.83 for shoulder tests, and -20 and 0.58 for cervical and thoracic spine. According to Burns et al. 2016, in patients with cervicothoracic pain and shoulder pain, in the cervical spine mobility tests, the percentage of agreement ranged between 48% and 76%. The kappa coefficients ranged between -20 and 0.58 for the evaluation of joint mobility of the cervical and thoracic spine. Reliability varied considerably for cervical examination, and was much better for shoulder joints, kappa of -0.24 and 0.83. Holt et al. 2018, observed an agreement in the most rigid segment in 54% of the observations. Humphreys et al. 2004, used a congenital spinal block as a gold standard to assess the validity of motion palpation in detecting true fixation. There was substantial general agreement for the identification of the segment with the highest hypermobility, kappa equals 0.65, sensitivity between 55% and 78%, specificity between 10 and 98%. This study indicates that relatively inexperienced examiners can correctly identify fixations in cervical segments. We have here a summary table of the results about the studies presented above, where overall good reliability of the segmental mobility assessment tests used in cervical osteopathy can be observed. Passive segmental mobility tests have good inter-examiner reliability. At the level of the cervical spine, they allow to detect the most rigid, hypomobile segment. These allow a topographic diagnosis, and can be completed using a cluster of segmental mobility tests. They have good sensitivity and specificity. Here you have the bibliography used in this presentation. All these references can be found in PubMed.
Thank you for listening.